Good morning, and welcome to our Who is Jay mental health webinar series presented by the SMA Healthcare Foundation. The Foundation enthusiastically supports SMA Healthcare in its mission to improve lives by providing exceptional substance abuse and mental health services. Each May, the Foundation hosts a day-long mental health symposium in Daytona Beach, Florida, which includes various educational breakout sessions for professionals in the field and for members in the community. This year, due to COVID-19, just like everything else, our event was canceled. However, we asked some of our scheduled speakers if they would be with us on Fridays this month, and we thank them for agreeing to participate. For those of you watching today who have attended our symposium in the past, please mark your calendars for next year's event, which will be held May 13th, 2021. These webinars could not be made possible without the support of numerous sponsors and the Jay's Hope Fund. This fund was created in remembrance of Jay Ashby by his family in order to provide mental health and suicide awareness education in our communities. On behalf of our board of directors and staff, we hope that you enjoy today's webinar, and we hope you will join us for the other webinars in this series. Thank you.
All right, so that was a message from Jennifer Secor, the Executive Director of the SMA Healthcare Foundation. At this point, I'd like to introduce Dr. Amie Newins. Dr. Newins is an assistant professor in the Department of Psychology at the University of Central Florida, the director of the Center for Research and Education on Sexual Trauma at UCF Restores, and the director of Continuing Education for UCF Restores. UCF Restores is a treatment clinic that provides clinical services to veterans, active duty military, first responders, survivors of trauma, and community members experiencing post-traumatic stress disorder and trauma-related concerns. Dr. Newins received her BA in psychology from Mercer's University and her master's and PhD in clinical psychology from Virginia Tech. She conducts clinical research and serves as the clinical supervisor in UCF Restores. Her research interests are broadly focused on the relationship between anxiety and health risk and an emphasis on trauma. On behalf of the SMA Healthcare Foundation, it is my privilege to welcome her and turn the presentation over to Dr. Newins at this time.
Good morning. Welcome, everyone. Thank you so much to the SMA Healthcare Foundation for inviting me to be here today. I really appreciate the opportunity to be here and to speak with you all. I will be talking today about PTSD and trauma in military personnel, veterans, and first responders. So for an outline for today's presentation, I'll start by talking about what are potentially traumatic events in terms of what we consider from a mental health diagnostic perspective. Then what are some common reactions when people experience traumatic events? What does PTSD look like, and what are some other mental health diagnoses that sometimes follow trauma? And then some factors that influence PTSD symptoms and what they may look like. And then also talking, given the current circumstances, about the impact that COVID-19 has had on military personnel and first responders, and then briefly discuss some treatment options for those who are experiencing mental health difficulties as a result of trauma exposure. So to start with, what are potentially traumatic events? So potentially traumatic events from a mental health diagnostic perspective involves exposure to actual or threatened death, serious injury, or sexual violence. Now, this exposure can occur in multiple ways. It can be a direct experience where the person seeking treatment actually was the one who experienced threatened death or sexual violence. It can also involve witnessing it happen to someone else, so being a bystander who sees it happening, or learning that it has happened to others. So even if someone was not there when the event occurred, they may learn that it happened to someone. In order for someone to meet criteria for trauma from a mental health diagnostic perspective, if they learned about it happening to someone, it has to be someone that they are close to. So someone like a family member or a friend of theirs. And then the fourth exposure type involves repeated or extreme exposure to aversive details. And this exposure type most commonly occurs for people who have positions that involve, work positions that involve this type of exposure. So this is really an important piece for our first responders and sometimes our military personnel as well, because they may be going in after a traumatic event occurs and seeing the aftermath of what happened. So thinking of the first responders who had to clean up after the Pulse shooting, or our military personnel who have to go into a village after there has been an attack, things of that nature. If this exposure occurs via electronic media, like looking at pictures or seeing videos, then the exposure does have to be work-related for it to meet criteria for traumatic exposure from a mental health diagnostic perspective. And just a couple of examples of traumatic events, these include natural disasters, terrorism, physical or sexual assault, motor vehicle accidents, and combat. So for military personnel, I want to talk about some of the most common potentially traumatic events that they're exposed to. So combat and deployment related traumas, these are the events that we most commonly think of when we think about military personnel and trauma exposure. So these are the things like an intermittent explosive device or IED explosion while on deployment, or their forward operating base being attacked by mortar fire. Things of that nature would fall in this category. Military sexual trauma, this is when a military service member experiences sexual assault while they are serving in the military. The VA also includes sexual harassment in their definition of military sexual trauma as well. Military personnel can also be exposed to training accidents. So sometimes people haven't even been deployed yet, but they've experienced a traumatic event. This could be a misfire on the shooting range. This could be some sort of vehicle accident that occurs during training. All of these things also happen to our military personnel. When working with military personnel, most often their exposure to trauma is either they directly experienced it or they witnessed it, or possibly both. So with the IED explosion, maybe they were in the Humvee that drove over the IED and they witnessed someone who died as a result of that IED. That said, there are some military job assignments that involve exposure to aversive detail, like those people who have to go into a village and assess the damage after an attack, or some drone operators who have to see events from a distance, but they aren't physically there when it occurs. And then there are some events that are learned about as well. So maybe someone on a different unit experiences experiences a traumatic event and you learn about it, and that person was your friend during training. For first responders, here some common potentially traumatic events. They are often called upon to put their own life in danger or risk being injured during a call. So thinking of our firefighters who may have to go into a burning building and put their own life on the line, or police officers who respond to calls where they may be shot at or experience some form of physical violence. Paramedics may risk exposure to certain diseases while they are providing aid. Some very common themes that we see are when calls involve pediatric deaths or pediatric injuries, those can be particularly difficult for first responders, and I'll talk a bit more about that later. then they may also need to respond to completed or attempted suicide, where they're exposed to actual or threatened death and sometimes serious injuries, and then motor vehicle accidents as well. Depending on the timing of when the first responder gets on scene would determine whether it's direct experience, witnessing it, or if it's exposure to aversive detail. But again, for our first responders, any of those would meet criteria. And there are some jobs that primarily involve exposure to aversive details. Some detectives who work in cyber crimes, their job may involve a lot of exposure to things that they don't directly see or directly experience in person, but they're seeing very horrific images on their computer screen repeatedly. So now, what are some common reactions to trauma? Well, some common physical reactions or things to look for: feeling tired or not being able to sleep very well, which can further contribute to that fatigue. GI upset, whether that's nausea, vomiting, diarrhea, headaches, or just general aches and pains in the body. Changes in startle response. So what this looks like is things that wouldn't cause you to jump or startle in the past, all of a sudden do. And we also know with that fatigue, insomnia, there can be some impaired immune system functioning as well. In terms of emotional reactions after trauma, we can see agitation or feeling angry a lot, or just feeling generally frustrated, having a hard time letting go of that frustration, and snapping easily at maybe family or friends. There can also be emotional numbing, just shutting down emotions completely to try to not feel anything. Anxiety, guilt, maybe about not doing enough during the circumstance or during the event. Sadness, particularly if someone was injured or killed in the traumatic event. Sense of failure, and that can feed into the guilt as well if someone believes they didn't do enough during the traumatic event to help others. And loss of pleasure from regular activities. So things that you used to enjoy maybe just don't seem that fun to do anymore. Some additional common emotional reactions include intrusive thoughts or memories. So this is when the event keeps coming up in the person's mind, even though they don't want to think about it. Dreams or nightmares about the event. Impaired concentration. So when they sit down to do their work or do some sort of household chore, they just can't stay focused on it. Impaired memory, so forgetting things, having more of those occurrences where you walk into a room and don't remember why, or forgetting items at home, things of that nature. Impaired decision making, so just being unable to make decisions, even simple decisions like what they want to eat for dinner may be difficult for some people. And then self-blame or self-doubt. So particularly for people who may feel guilty or feel like they didn't do enough during the event, they may then blame themselves for what happened. They may also doubt their ability in the future for other similar calls. And then decreased self-esteem or self-worth is related there as well. Behaviorally, sometimes we see that people will withdraw socially. They won't want to interact with their family or friends as much anymore. And they can also, on the other hand, we can see increased relationship distress or conflict. And sometimes these two things go hand in hand. So someone's arguing more with their spouse and arguing more with their coworkers, so they just withdraw to avoid those conflicts. We can sometimes see increased risk-taking behaviors, so driving over the speed limit or driving a bit recklessly, substance use behaviors that may involve risk or driving under the influence, and then emotional outbursts. So these could be anger, although it could also be outbursts of sadness or fear or anxiety. And then some people will deny the need for rest or recovery. They'll be told by their job, take a few days off. recoup from this, but they'll say they don't need it, and that may be their way of trying to cope with the event by staying busy. So what are some common patterns of reaction to trauma? So one thing that has been shown in the literature repeatedly is that most people experience some of these reactions following a traumatic event. That's normative for most of us. So how do we know who needs intensive mental health treatment and who does not? And what we can see is that there's actually 4 patterns where there's a subset of people who will have chronic elevated symptoms. These are the people who definitely will need treatment of some sort for their symptoms to come down. There's some people who will experience somewhat of a delayed onset, so they'll experience some symptoms initially that will creep up over time, and they also will likely need intervention at some point. Then there are some people who will demonstrate recovery. So they'll experience a fair amount of distress initially, but their symptoms will come down over time, even without a lot of formal intervention. Now, this doesn't mean that they're not getting support from their social network, but maybe not a lot of formal intervention. And then actually the bulk of people will fall in the resilient group. So they'll experience a little blip in symptoms initially and then return back down to approximately their baseline, usually within a month or so. So that's a general pattern. And then here you can see that pattern bears out. There's a graph for people who lost their spouse. There's a graph for college students where a school shooting occurred. And we're seeing in general these same 4 groups across these. And then here is the deployment trauma. And again, similar groups. But the important thing to note is that that resilient group or the low symptom group tends to be the biggest group. And so these people with appropriate social support will be able to cope with their symptoms on their own. So with temporary stress reactions, this is immediately following the trauma. And here, this again is very similar to what we saw in those previous graphs. The majority of people will experience normal stress reactions. So they will experience some distress, and it may even interfere with work a bit or their home life a bit for a brief period of time. Then if after a few weeks they're still having persistent negative feelings, or they're having problematic behaviors that aren't going away, or they're still not performing at work as they would expect or their employer would expect, and they really haven't shown a lot of improvement, those are the people who have a temporary stress injury. But this is not yet a mental health disorder, and they may respond to mitigation or coping strategies, which I will also talk about in a little bit. So when do symptoms become a disorder? Well, it's really important that when we're considering a mental health diagnosis, that we're looking at, are symptoms causing impairment somewhere? So are they causing problems for someone at work or in their social life, whether this is at home with their family or out with their friends? And is it interfering also at home, maybe with getting things like chores done or engaging in childcare responsibilities, things of that nature? And also when symptoms aren't remitting, that's another thing that we look at, because again, with trauma, most people experience some symptoms initially that will go down over time if they engage in their coping strategies. That said, it's also important to consider professional intervention, even if symptoms haven't been present for very long, or there's not a lot of impairment in other domains, if there are thoughts of suicide or homicide, or if the behavior is resulting in legal problems or severe problems at work. So I'd like to talk for a couple of minutes about what is PTSD and what are some other mental health diagnoses that we see after traumatic events. Before I talk about what those are, I want to give a couple of caveats or important considerations to keep in mind. When someone is exposed to trauma, it's really important that we don't assume that they must have PTSD simply because they've been exposed to trauma. They may have another mental health diagnosis, or they may not have any diagnosis at all. They may end up falling in that resilience group. So trauma exposure isn't sufficient for a mental health diagnosis, and PTSD is not the only diagnosis that can occur after trauma. And so it's really important for clinicians and for loved ones to keep that in mind. It's also critical to not deny that someone might be having trouble dealing with a very traumatic event. So on the flip side of that, when we are seeing difficulties, we don't want to assume just because maybe they've been through other difficult things in the past, or we think of them as a very strong or resilient person, that they're not having any difficulties. And again, that third point is that people may have disorders that are not PTSD, or they may have PTSD and additional diagnoses. And trauma-related disorders, they can occur because of a single traumatic event, like responding to one motor vehicle accident, or because of multiple events. Maybe it wasn't that first motor vehicle accident that a firefighter responded to, but the 10th one that had similar circumstances that really got to them. And it's all that accumulation of seeing that repeatedly that's bothering them. So with PTSD, what does this look like? Well, first, symptoms are present for at least 1 month. So that's an important thing to keep in mind for diagnosing PTSD. And then there's 4 symptom clusters. The intrusion symptoms, these are the memories that are coming up when people don't want them to. So this is intrusive memories where the thought of the event just pops into the person's head and they weren't trying to think about it. And it's really bothersome when that thought pops into their head. This can also be nightmares about the event or similar circumstances to the event. This cluster also includes reactivity to trauma reminders. So some people may notice their heart starts racing, or they feel really anxious when they smell diesel fuel that reminds them of the motor vehicle accident that they responded to, or when they see trash on the side of the road, which reminds them of watching out for IEDs when they were deployed. The second symptom cluster, these are the avoidance symptoms. So this is staying away from those trauma reminders. So trying not to drive routes that involve known trash areas or areas where there's trash on the side of the road. It can also involve maybe asking someone else to fill up the gas tank on the vehicle so that they don't have to smell diesel fuel, things of that nature. And avoidance of memories as well. So trying not to think about it and maybe using substances like alcohol or other drugs to try not to have to think about the event as much. The third cluster is negative alterations in cognition and mood. So these are things like blaming oneself for the event or the outcomes of the event, experiencing some sort of negative mood state on a fairly consistent basis. That could be anxiety, it could be anger, it could be sadness. And this also can include loss of interest in activities that they used to enjoy. Then the fourth cluster, this is the alterations in arousal and reactivity. So these are the increased startle response or feeling like you have to constantly be on guard or on watch. So maybe thinking you need to sit in the corner booth at a restaurant so that you can see everything that's happening around you, or needing to be near exits so that you can get out quickly if something bad happens. And this also involves the anger and irritability piece of PTSD as well. Another common outcome of exposure to trauma, though, is depression. And depression, this involves a down or low mood. It can also involve feeling tired or fatigued, a lack of interest in previously enjoyed activities. So there is some overlap with PTSD symptoms as well. But here the focus really is on this low mood and maybe feeling worthless, changes in weight. It can be a weight gain or a weight loss, often associated with changes in appetite, either eating a lot more than is typical or feeling like you can't eat at all. Trouble concentrating, and then oversleeping or undersleeping is also common, maybe staying in bed all day and sleeping most of the day, or not being able to sleep at all. And then thoughts of death can also occur with depression. But there are also some other disorders that we should watch out for with individuals who have been exposed to traumatic events. Some can include panic disorder. So this is when people experience panic attacks from out of the blue for no apparent reason. They can't identify why. Agoraphobia, where they're afraid of being in situations because they're afraid they might have panic symptoms and not be able to escape and get help. Generalized anxiety disorder is just worrying about a lot of different things. So it may be worrying about events going on in the world, your financial status, the health of people in your family. Illness anxiety disorder, worrying a lot about developing a specific illness. And we sometimes see this with first responders who have maybe responded a lot to heart attack calls, and so they worry a lot about developing a heart condition that will cause them to have a heart attack in the future. Obsessive compulsive disorder, so this involves thoughts that pop into the person's head that are distressing to them, and then doing behaviors to try to minimize any negative outcomes. This can sometimes occur if, let's say, a first responder has been on calls where they've been exposed to hazardous substances. They may engage in a lot of cleaning behaviors after that and develop obsessive compulsive disorder as a result. And then substance use disorders as well, where people use alcohol or other drugs in a problematic way. So some factors that influence PTSD symptoms in military members and first responders. So one is the number and severity of traumatic events. So when people are exposed to multiple traumatic events, it may wear down their coping ability. Maybe they haven't fully coped with the previous traumatic event and another one occurs, which interferes with their ability to cope with that next one as well. And the number of traumatic events may also begin to impact people's worldview. So I recently saw a quote about law enforcement officers where they spend 99% of their time dealing with 1% of the population, and that spending all of that time dealing with individuals who are creating problems in society then leads to alterations in how dangerous the world seems. Then timing between events may also affect outcomes, and that goes back to that idea of have people had time to cope before the next one occurs. And then in terms of severity, the greater the injury, the greater the life threat, there tends to be more severe symptoms after those types of events. The location of the traumatic event can also matter. So if a person doesn't have to go back to the area where their traumatic event occurs, that may make it a bit easier for them to kind of put that out of their mind. Whereas if they have to drive by it or drive by similar locations or even go into the place where the event happened repeatedly, that may be more distressing for them. Involvement of children. So I mentioned this earlier a bit. When children are involved, that seems to be particularly bothersome to people. And this seems to relate. A lot of people tell us that children are innocent. They didn't deserve for this to happen to them. And so seeing serious injuries to children can be difficult for people to come to terms with. So if children were injured or if they died in the event, that can affect symptoms, as well as if the person has children of their own, particularly if they have their own children who are of similar ages to the children affected in the traumatic event. That seems to be particularly bothersome because they may, even during the event, have thought about their own child and what they would have gone through if this event had happened to their own child. With sexual trauma, some considerations to keep in mind are who was the perpetrator and how often does the person have to interact with that perpetrator following the event. Also, how will the person's relationship with the perpetrator affect their worldviews? So if it was someone they thought they could trust before, that may have a much different impact on their worldview than if it was a stranger. But if it was a stranger, there still may be impact on worldview because it may just make the whole world seem dangerous. Then the fight, flight, or freeze response is also important to consider with sexual trauma. A number of sexual trauma survivors experience a freeze reaction that was physiologically based and beyond their control. And that can lead to some self-blame and guilt. If individuals experienced any level of sexual arousal, or when men experience a sexual assault, if they are anally penetrated, they can sometimes experience ejaculation as a result of that, even though they did not want the intercourse, nor did they enjoy it when it was occurring. That can also lead to some doubts about, was this a sexual assault? What does this mean about my sexuality? And raise some of those questions. Then for first responders, if they are responding to a sexual assault, if they have their own history of sexual assault, that can impact the effect of responding to these types of events, or if they know someone who's experienced a sexual assault. And if children were involved, having a child of similar age to the victim can also affect responses. Moral injury. So this is the idea that some traumatic events involve actions or inactions that conflict with a person's moral beliefs. And an example here would be if someone was protecting a forward operating base during deployment and they had to shoot a civilian who was entering the FOB because of potential threat. If they later learn that that person was innocent, that may conflict with their belief that we shouldn't kill innocent people, and they may experience some guilt associated with that and shame that they did that. So that is another component to consider. And then responses received post-trauma. How did others react? Did they believe them? Did they believe how bothersome this was for the person? And what level of social support, as well as sometimes tangible aid, did the person receive to help them cope following the traumatic event? Where with more social support, more aid, people tend to cope better. So now I'd like to spend a few minutes talking about the impact of COVID-19. So COVID-19 and potentially traumatic events. So people are potentially directly experiencing severe complications of COVID-19 right now. They also may be facing, in particular, our first responders, medical personnel, some of our military personnel, and essential workers may be facing threatened or actual exposure to the coronavirus on a frequent basis, which may be bothersome to them. They may also be witnessing others experiencing the severe illness of COVID-19 and seeing those outcomes for people. And then they may also be exposed to aversive details of others experiencing serious illness as well. There are also some additional stressors that some of our military personnel and many of our first responders are facing as a result of COVID-19 that aren't just limited to potential traumas. So many of them are having to work increased hours or increased shifts. If someone is exposed to COVID-19, they may have personnel out, which then requires people to pick up shifts to cover. They may have concerns about exposing their family to the coronavirus, or may have to be separated from their family because they were potentially exposed. Also, for many of us, our family members are spending more time at home, which, while that was nice to begin with, sometimes can start to wear on us and cause stress over time. Then we couple that with decreased social engagement. We can spend less time with our friends, and a lot of times that has to occur digitally. And decreased options for enjoyable activities as well because of our physical distancing requirements. So what can we do to help people cope? So we can help people make a coping plan. What strategies have helped them in the past? What have they used to get them through difficult events in the past? And how can previous self-care activities be modified for the current situation? So if someone previously enjoyed exercising at the gym, but they're not able to do that right now, then is there something they can do either outdoors or at home that would meet that need? Or if they enjoyed playing games, are there online games that they can play with friends? And how can they connect with others for social support via phone, Zoom, FaceTime, things of that nature? Then, of course, if symptoms are persisting, consider formal mental health treatment. And here, I'm just going to leave the slide up for a moment, but here's some examples of coping strategies that people may consider. Now I'm just going to spend a few moments talking about treatment. So when considering treatment after a traumatic event, if someone does seem to be experiencing lasting mental health symptoms, then we need to consider what level or what setting is most appropriate. And so the severity of symptoms can inform, does the person need outpatient treatment, which may involve weekly sessions or monthly sessions, intensive outpatient treatment, which may involve 3+ sessions in a week, partial hospitalization, where people are at a facility for most of the day but tend to go home at night, residential programs, or inpatient. And again, the more severe the symptoms, and also taking into consideration risk to self and others, the more intensive of a setting we would want for the person. And then there are treatments that are individual, there are group treatments, and there are treatments that combine both of those. And what is the best fit for this person, and what are they most interested in participating in? Because one of the best predictors of treatment outcomes is if people get an adequate dose of the treatment. And if people want to do the treatment, or they got to select what they're doing, they're more likely to attend it, which increases the likelihood that they'll get an adequate dose of the treatment. So here I've listed a few treatments for trauma-related disorders and problems. And I'm going to talk about a few of these in a bit more detail in the next couple of minutes. I'm not going to talk about medications because as a psychologist, that's outside of my scope. So exposure therapy for PTSD. There are two types of exposure that are typically used for PTSD. One is imaginal exposure. So this is where people are asked to think about that trauma memory repeatedly in their sessions and potentially also at home. And this seems counterintuitive because people with PTSD don't want to think about their trauma. But the idea behind this is, if I tell you to not think about pink elephants, most people just had a pink elephant pop into their head. And so people with PTSD are living their lives saying, don't think about X, that traumatic event. And so with imaginal exposure, we make it so it's not a pleasant memory to think about, but it's something they can tolerate. In vivo exposure, this is in real life exposure. So this is exposure to trauma reminders, maybe the smell of the cologne that the perpetrator wore during a sexual assault, and also exposure to places or events that are viewed as unsafe following the trauma. So this may be going to restaurants when it is safe to do so, or being in crowded environments, again, as it is safe to do so per health and safety guidelines. With exposure, what we typically see for people is that when they go into an event or a situation that is distressing to them, their anxiety increases. And then they leave and their anxiety goes down. And basically what that teaches people is leaving is a really great way to make their anxiety go down. What we do with exposure is actually prevent that escape and let their anxiety come down on its own. So they can learn that they can tolerate it and that their anxiety will come down even though they don't leave the situation. And what we see is over time, the graph on the right shows that over time, people's distress comes down even between sessions where it's less anxiety provoking to enter the situation. So trauma management therapy, this is a treatment that combines imaginal exposure to that trauma memory, in vivo exposure, and then group therapy that targets behavioral activation. So getting people doing activities that they stopped doing to get them active again and alleviate depression. Sleep hygiene, keeping a consistent bedtime and wake up time, and engaging in strategies to help them sleep better at night. Anger management, how to recognize when you're starting to get angry, and then problem solving skills to help them identify ways to bring down their anger. And then social reintegration to help them either strengthen or make new social connections. Prolonged exposure, this is another treatment for PTSD that involves imaginal exposure. And there's an in vivo exposure component that's primarily conducted as homework. Cognitive processing therapy. With this treatment for PTSD, you identify the thoughts keeping the person stuck in their PTSD symptoms, and then teach the person cognitive restructuring strategies to help them look at their self-blame thoughts, or if they blame another person for the event, and also examine any thoughts related to safety, trust, power and control, intimacy, and esteem that may be keeping people stuck in their PTSD, and change those thoughts, which will then allow them to act differently in their lives. Some other treatments. So behavioral activation, this is primarily used for depression. And as I mentioned earlier, it helps people engage in activities to reduce their depression. So maybe if people have stopped exercising, it's getting them to do that again. Or if they've stopped calling their friends, starting to do activities like that again. Anger management, I also talked about a bit before. Cognitive behavioral therapy, this is just an umbrella term for treatments that help people change thoughts and behaviors. So cognitive processing therapy is a treatment that primarily focuses on those thoughts, whereas behavioral activation is more of a behavioral approach, and sometimes these things are combined, or strategies from these treatments are combined under cognitive behavioral therapy. Motivational interviewing, this is a treatment that was initially designed to help people stop using substances and get them to make that decision. But it can help with increasing motivation for other behavioral changes, even engaging in treatment. And then relapse prevention, this is a cognitive behavioral based treatment to help people stay off of substances. And so that may be one to look for people who need substance use treatment. And thank you all for being here today. And now I will take questions.
All right. Well, thank you. That was a super informative presentation. I was just starting to digest it all, and then it was on to the next point. So it was great. So we'll take questions. If anybody has any questions, you can chat them right here in the chat box. And I'm actually going to put up a screen so that if you all want to, you can download a copy of the presentation. So that copy of the presentation is located in the center at the top, kind of in between the chat box and in between our video here. So you can download that. Also, while we're waiting for questions to come in, there is a link to the CEU request form. So again, if you want credit for attending today's session, you can click on that link, make sure you fill out that form, and SMA Healthcare Foundation will get in touch with you to make sure that you get your certificate and your credit. So, and then the last link we have in the center is the evaluation form for this session. So we'd really like to know what you think. We also have a spot in that evaluation form for ideas for future sessions. We're always interested in rolling out new content to help the mental health community. We want to know what you're interested in. So if you could fill out that evaluation form, that would be super helpful as well. So just have a few comments that have come in I thought were relative. We had a person from the Ormond Police Department say they had one employee that had to retire because the police department due to PTSD because of a traffic fatality, and it was a very hard case. So are traffic fatalities, is that something that seems like a very commonplace activity in law enforcement? What is the percentage of that happening and kind of introducing PTSD?
So I don't know the percentage in terms of, for law enforcement, how many are due to responding to a traffic fatality. I do know that there's data to suggest that motor vehicle accidents, just because of their prevalence, are one of the more common traumatic events that lead to PTSD, just in terms of straight numbers. But if you look percentage-wise at the number of people who are in a traffic accident who develop PTSD, it's actually low. It's just because the base rate is so high that straight numbers make that high. But certainly traffic fatalities, they can be particularly gruesome to respond to. And so our first responders can be seeing just absolutely horrific things when they arrive on that scene. And they may be having to clean up body parts or search for body parts that have been thrown from the vehicle, things of that nature. And so when they are particularly gruesome, and again, particularly when they involve children, those are the ones that, if I'm thinking about caseloads, those are just very bothersome to people because they just stick with them. Those images just keep coming back in their head and can make it difficult to fall asleep at night, and just are really difficult to cope with getting those things out of their mind.
Absolutely. Next question comes in. What have you heard about the possibility of treating trauma victims with EMDR?
So EMDR, this is eye movement desensitization retraining, or reprocessing, I believe. And so this treatment also does typically involve an exposure component. So people typically are asked to recall their traumatic event, and they do this while moving their eyes. Usually there's a light or a hand movement that the therapist learns to do to help the patient do lateral eye movements while they're recalling the event. And so the exposure component will certainly help with PTSD symptoms. And there is some theories that argue that the eye movement aids in reducing PTSD symptoms as well.
Okay. We have some more questions coming in now. All right, next question is from Debbie. She asks, in regards to substance abuse setting, can you suggest which screening tool you would find appropriate? Although we do not usually treat, we do refer out.
That's a great question. So in terms of some screening tools for substance use, the audit, the Alcohol Use Disorders Identification Test, that one can be particularly helpful. There's also the DAST, which is the Drug Abuse Screening Test. If it's common for if marijuana use or cannabis use is common, then the QDIT, which is the Cannabis Use Disorder Identification Scale, is also available. The audit, because it was produced by the World Health Organization, is freely available, and I believe the DAST is freely available from, I think it's NIH. So those are some that would potentially be helpful for substance use screening.
Okay. And she adds this for PTSD screening in the substance abuse setting, specifically BCS, so much use is trauma related.
Okay. I apologize. I misunderstood the question earlier. Thank you so much, Debbie, for clarifying. So for trauma exposure, one measure that is freely available from the National Center for PTSD is the life events checklist for DSM-5. So that can get a pretty broad range of exposure to trauma. And then the National Center for PTSD also puts out the PTSD checklist, or the PCL for DSM-5, and both of those are freely available on the National Center for PTSD's website.
All right, and she thanks you for that. Mm-hmm. And we can take more questions coming in. While we're waiting for people to type in questions, one of the things that I found really interesting was the connection that you made specifically to smell a number of times and recalling an incident, a traumatic event. And it seems that, things that I've read, that smell has such a powerful reaction for people in creating memories. I remember reading something about how one of our senior citizens, when they smell oranges, that reminds them of the holidays because they didn't get oranges on a regular basis. Oranges were kind of a treat during the holidays, and that is a strong link for them. So knowing that it's so strong, you mentioned diesel fuel and things like that. How do you deal with that as if it's a trigger issue? How do you deal with that if that's commonplace in the world that somebody functions in?
Yeah, that's a great question because you're absolutely right. Both positive and negative, smell just takes us back to the situation that it reminds us of. And so when possible, if you're doing something like imaginal exposure, if there's something that you can safely bring into the session, whether that is having the cologne that a perpetrator wore or getting a small amount of diesel fuel. With diesel fuel, you would want to waft it. You wouldn't want to put it right under someone's nose. Or there have been certain food items or alcohol sometimes for sexual assault is another smell that comes up, or cigarettes. If you can get something that smells like that and bring it into the session and integrate that into the imaginal exposure, or even do an exposure just to that scent, that can be really helpful for the patient.
That's fascinating. That's interesting. So you reintroduce it into the treatment.
Okay. Absolutely.
All right, next question comes from Shonda. She asks, do you feel alternative methods of treatment, particularly the rising support for medical marijuana, is a viable treatment method to refer PTSD patients?
That is an excellent question as well. I am not an expert in this area. I will say for PTSD, it seems like the literature is still, we still need more research to tell us how effective medical marijuana will be for PTSD. There are some people who find it very helpful. And then I think if people are going to integrate something like medical marijuana, it's just making sure, depending on the treatment modality that you're using, that it wouldn't interfere with the treatment that you're doing. So if I have a patient who is using medical marijuana, I ask them not to come to session under the influence of that, because the learning, I use a lot of exposure therapy, and the learning is better if they're not under the influence of the substance. And so when people are finding that helpful, then I do let them continue that because I would never want to take away something that a patient is finding helpful, but also making sure that I think about ways to make that fit with the treatment that I'm doing.
Okay, next question comes in from Susan. And Susan, by the way, is one of our sponsors that made this event possible. She asks, can you offer strategies to help someone possibly suffering from PTSD to get help?
Yeah, so that can be another, everyone has wonderful questions today. Because as we know, with most mental health difficulties, seeking treatment can be a challenge. And to think about the topic of first responders and military personnel, these are the people who help us. And so the idea that they are going out to seek help, I think there can sometimes be a struggle getting over that hump that our helpers need help. And I think one strategy that can be helpful is the idea that in order to help others, we need to be at our best. And so if someone is experiencing PTSD symptoms, that's likely interfering with their ability to do their job to the best of their ability. And so that may be a motivator to help them to go get treatment, or identifying other motivators. So setting an example for one's children, that can be another really common motivator for treatment. And then also, if people are willing in departments who have sought treatment and gotten help, and they're willing to share their story about that, that can be really powerful because it reduces that stigma. It's someone maybe from your fire department or your police department or a neighboring one saying, hey, I get it. You know, that call that you experienced, that sounds really tough. I had one of my own in the past, and here's what I did to help me, and now I'm back here. And just trying to help it be seen as more acceptable for our military and first responders to get help.
So I see we have a couple more people typing in questions, and we'll do kind of a final call for questions here. In the meantime, I have another question that kind of came up, which I think is interesting. You talked about people kind of admitting to it, but or kind of understanding that they might have been subjected to PTSD and accepting that as a condition. Do you notice the difference in veterans? I know we don't have a lot of World War II veterans left, but there are some. And, of course, then we're the Vietnam War and the Gulf conflict. Do you see difference in veterans and kind of their ability to recognize and accept that diagnosis of PTSD?
I do. When I'm thinking back to particularly my work at the VA before I took my job at UCF, it does seem like acceptance of PTSD and the need to seek treatment is increasing among our veterans, which is very encouraging. And even some of the older veterans were starting to say, okay, I finally recognize this now. And coming in and seeking treatment for things that they had been dealing with for many years. And that brings up the idea that sometimes it can be tricky when you're looking at PTSD. A lot of times you're asking, so did you lose interest in activities? Well, when someone is 70 and their traumatic event happened when they were 22, it's like, I don't know, did I? And like, what does that mean now? And so we have to be sensitive to that and look at what activities are they engaging in, and are they enjoying those activities, and what would be typical for people of their age, and consider some of those factors when we're evaluating them. But it is encouraging to see a bit of an increase and growing acceptability of being out with a mental health diagnosis.
Okay. Well, we got a thank you message from Evelyn. So those questions and responses are great. Thank you so much. And so it looks like everyone's really had learned a lot in this session. And we'll do a final call for questions here. Again, want to thank everybody for attending. Want to thank our sponsors, the coordinator of this, the SMA Healthcare Foundation, Jay's Hope Fund, Advent Health, Brown & Brown Insurance, E&M Pros, the Simpkins Family Foundation, SMA Healthcare itself, as well as FPL. All right, looks like our final question/comments come in. This is from Lindsay. Lindsay types, I've had professionals tell me before PTSD is diagnosed only after they have been diagnosed with depression and anxiety. To me, it seems like they are symptoms rather than layering these issues first. It seems from the presentation you agree. Would that be true?
Yeah, so it is. Diagnoses, particularly for mental health, are complicated, and they're really complicated by the fact that we're relying on patient report and their overlapping symptoms. And so sometimes if someone comes in and really the depression symptoms are what's bothering them, they may get a diagnosis of depression initially because that is really what is coming through strongly. We can't give a blood test and say, is this depression or is this PTSD? And so if really what seems to be the problem is depression, that label might get put on. And then later, maybe either as the depressive symptoms start to reduce or potentially during treatment, maybe if the clinician is saying, well, let's do some behavioral activation and have you go and go out to a mall or something like that to do some shopping, or ask a friend to go to a restaurant with you. And the person that we've diagnosed with depression might start saying, yeah, I don't think I can do that. And as we find out why they don't want to do that, it's because they have anxiety about being in that situation that goes back to their traumatic event. And then we may reconsider and say, okay, maybe this is actually PTSD instead of depression, or maybe it's PTSD in addition to depression.
All right. Well, Tia, this has been a great presentation. I've learned so much. I hope everyone out there has learned so much as well. There's a lot of great information. If you want a copy of this presentation, you can download it right there. It's the PDF in the middle called Trauma and PTSD in Military and First Responders. And Dr. Newins, any final thoughts before we close the webinar down?
I would just like to say thank you all for the questions. Thank you for attending today. And thank you again to SMA Healthcare Foundation for having me here today, and to all the sponsors for supporting this webinar series. So thank you so much. I hope that everyone has a wonderful day.
Excellent. Well, thank you for joining us. On behalf of the SMA Healthcare Foundation, I'd like to thank you for attending and encourage you to attend our next session on Friday, October 23rd at 10:30 a.m., where we'll be talking about telehealth. So until then, we'll see you next time.